Okay, well, we're going to get started. Thank you for being here today. This is Gray
I'm on,
Anatomy,
Connie.
and today we have Dr. Kelly Crabtree Wilson with us. She is been at LMH Health for the last couple of years. She's a local person, grew up in the Kansas City area, and her specialty is spine health and neurosurgery. So we're going to learn quite a lot today. We have a lot of people here who are registered. A lot of people have showed up. That's great. If you would put your questions as we go in the chat box, I'll be watching that and I will ask Dr. Crabtree Wilson your question as we go. But as always, before we begin, I want to uh, do a shout out to Capital Federal Bank and Sharon and David Katzman, who do provide the funds that keeps retroactive ticking and these wonderful Zooms coming at you, all this great information. So thank you for being here today and thank you for their support. And if you see the Katzmans or go to the bank, or even if you don't use that bank, stop in and thank them for their great support as a community for us as we learn more. And I think that Dr. Katzman's here somewhere. There you are. Okay, I mean Dr. Crabtree Wilson. So I'm going to introduce her, and she has a PowerPoint for us, and she's going to get the party started. So thanks for being here, and I'll hand it over to her. Welcome,
Thank
Dr.
you. My
Wilson.
pleasure. As you mentioned, my name is Kelly Crabtree Wilson. I am a neurosurgeon. I've been living in Lawrence for about 10 years, a little over. I have been at LMH for about 2.5 years, loving it here. I was previously at Stormont, where they were keeping me quite busy with a lot of traumas. So now I'm seeing more along the lines of like elective spine. Kind of some of the more routine run-of-the-mill stuff here at LMH, and it's been a wonderful change. My family is thrilled that I have come over here, and we are happy to continue to be part of this community. I trained. I did my undergraduate degree at Lehigh University, studying neuroscience. Have a master's in neurobiochemistry, and then went to med school at the University of Kansas, where I stayed and did the neurosurgery program at the University of Kansas. So I'm definitely a local girl in Rock Chalk. And then, I came out, moved here, and have been here in Lawrence ever since. So with that, we will get started. So today, just a little overview of some of the topics. I just wanted to kind of give a little background on some of the basics of the spine. Can be quite complex, and particularly as we age, there's a lot of things that can come up that can cause pain or weakness or neurologic dysfunction, all of which can impact your quality of life and your normal activities. So we're going to kind of talk about what's normal, what's not, things you can help, things you really can't help, but should be mindful of. And then I'm going to review just some kind of common spinal conditions some of you may have had. Just due to our time constraints, I'm kind of focusing on the lumbar spine today. I'm not, but obviously a lot of this applies to the neck and the thoracic spine as well. So, normal spine anatomy. This is the picture of the spine. So your cervical spine, what we consider our neck, is at the top here. So there are 7 bones. This is a model. You can see it. This is the front of your spine. This is the back. This would be the base of your skull. There's some very important vertebral arteries that run through there. The spinal cord runs straight through the middle, and then there's one nerve that runs out each side at every level in the spine. So next we have thoracic, as you can see here. So you have 12 thoracic vertebrae, which are the bones here in the front. The part that you can reach and feel, usually if you reach around your back and feel here, like that part is called your spinous process. And then your spinal cord is in front of that, in front of some bone. It's kind of surrounded. It's called the lamina. So this talks about, it shows a good picture of what we want the spine to look like. When I'm looking at you straight face ahead, whether you're facing me or facing away, your spine you should be nice and neutral. When you face to the side, you have these curves that naturally occur in the spine. So this is called your cervical curve. And this curve, when it leans this way, it's called lordotic. When something bends forward, we call it kyphotic. I will try to minimize my use of those words, but if I slip up, that's what those mean. And so your cervical spine should have a natural lordotic curve, thoracic should have a kyphotic curve, and then the lumbar should also have a lordotic curve. And overall, that should create a balance where the very bottom of your cervical spine, if I was looking at you from the side and I dropped it straight down, it should be right centered over your sacrum, which is the very lowest part of your spine. And when that stops being the case, it can start to cause a lot of problems, which we'll get into a little bit later. So, the aging spine, there are multiple things that factor into how our spine ages, how we age.
Are you
There are
on?
certain ones.
Yeah.
I Is there a question? Sorry. I thought I heard something. My apologies. So I kind of bring up the nature versus nurture, but nature is the genes or what we're given with, like what our cells in our body, um, what we're kind of predisposed to have, how we create bone, how we turn over that bone, how we are able to regenerate cartilage and muscle mass and how that all plays together. So things that over time can affect your bone, bone density is a very big one. And while we can't always do a lot to change that, there are certain things we can do. And so we'll go into that in a little bit. Maintaining healthy cartilage, some of that is just genetic factors. Some of that's also things we can do to help protect our body. Spine alignment, there are certain genetic conditions that can predispose to having abnormal spine alignment, where you can have excessive curve one way or the other, or an abnormal curve, which is called scoliosis. And then there's certain inherited inflammatory processes that can lead to having a more likely or more like predisposed to having more arthritis. You know, if your grandmother had arthritis terribly, kind of in every joint, and your father had it, and then you have it, it's not uncommon to see that. And so, um, while we can't always do a lot about those things, knowing, you know, that there is some things out of our control, but there's also things that are under our control. That's kind of the nurture, like how we treat our bodies, what we do for our jobs, for um, things that happen, whether repetitive trauma, sports, even in your youth. I have a lot of farmers I see, and they work very hard and they are pretty hard on their bodies. And a lot of times their spine will show that. So, heavy mechanical forces, repetitive, kind of improper bending, lifting, just straining your spine in an abnormal alignment. Over time, that repetitive nature can certainly cause a lot of stress and lead to increased wear and tear on the discs, which are the cushions between the bones of the spine, as well as the joints that help provide stability to and rotational motion of the spine, and then the muscles also surrounding the spine. There's also some pretty important ligaments. So there's a lot of different things that overall our health and how we take care of our body can be impacted, but also doing things with kind of the optimal posture and doing things properly, like, you know, probably most of our parents or grandparents told us growing up, is very critical. Um, so this here, this diagram kind of shows this is kind of that normal curvature. So there's this like cervical lordosis curve this way, then this thoracic curve, which is kind of soft curve reverse, and then the lumbar lordosis, and those should all balance out. As we start to age, we start to lose some height. These discs start to collapse. That's one of the first things that starts to happen. And so as those discs collapse, we can start to lose some of that angulation. Some of those discs have a lot more angle, and when they lose the fluid that helps keep them, they're not as hydrated, they get dried out, and they start to collapse. And so that will impact how that alignment wears. There's also factors like fractures or compression, things like that, or having some ligaments become unstable that can make that worse. But over time, yeah, as people naturally age, it is expected to have more curvature in your thoracic spine. So you almost have to kind of combat that with really optimizing posture and your core to, and if you've ever seen me in person or in my clinic, you know, I talk a lot about this. Basically doing everything you can to kind of offset that. I generally joke with people when they see me. I say, you know, I I aim for like military general, like chin up, shoulders back, activating your core. For those of us ladies that aren't quite as tall, which I'm on that side, I say like you when you're getting your height measured and you stand up really, really, really tall, all of that extra height you get when you pull yourself up is actually your core muscles lifting you. And so they take about a third of the load off of your spine. And that's huge. I mean, who doesn't like a third less work? So when we think about it that way, it's really, really important to have that activated. And it's also very hard to have great posture. It's very hard to have great posture in your neck, but not your lumbar spine. It's kind of like becomes an all or nothing thing. So here's some things you can do to optimize your posture and kind of help protect your spine and kind of prevent injuries and help slow degeneration as much as possible. One of the biggest things is physical activity. That can be a double-edged sword because a lot of repetitive, high impact activities will actually wear your joints down because it's just any mechanical force over and over again. Those discs kind of have to take it, and it's just they're more likely to have to wear down and lose some of their hydration if they're constantly getting pounded. Um, I would say nowadays, I think a lot of us, and those of you who worked in an office for a long time, like having, not bending over, not, typing with your head down. We encourage people to get stand-up desks to transition from sitting to standing. It's actually much easier to have good posture when you're standing, compared to sitting. The longer you sit, the harder it is. It just becomes so much easier to slouch down. And so, having a good chair, but really taking a break, standing up every, 30 to 45 minutes, even if it's just for 30 seconds, it helps you kind of reset. Having something where your chin is up and you don't have to look down, whether at your phone, your laptop, your iPad, whatever. I'm trying to have something propped up so it's eye level so you're not as tempted to hunch. That is super critical. Also, repetitive bending, lifting. You want to do things with your chest as upright as possible. So anytime you're lifting something, you want to squat and bend with your knees and try to keep your chest up and keep whatever you're lifting as close to your body as you possibly can. Um, the farther out that is and the farther you bend over at your hips, it becomes like a lever arm effect, where it's a lot of stress on your low back in particular when you're bending over and not keeping your chest up, and it really stresses your lower spine, and the discs and the joints down there. Okay, regular exercise. So I feel this is not really talked about a lot, but everybody starts losing muscle mass really in their like late 30s to early 40s. Um, and that means that like, I'm already at what I'm going to get. So I have to do more exercise every single year just to maintain the muscle I have. If I want to build muscle, I have to go above and beyond that. But just to keep what I have, I still have to do more work. And so I think that's important to know. It's also important to factor in for your diet, making sure you're getting adequate protein and having good nutrition because you really can't build muscle without that. Um, that being said, I think regular exercise, kind of low impact aerobic activity is very good for nearly every system of your body, but particularly like walking, gentle yoga is fantastic, for your core. I mean, it's probably absolutely the best thing you can do for your core. It works all these little tiny muscles around your spine that not a lot of things target, and it really helps stabilize your core. Same thing with Pilates. Swimming is really good. There's no weight bearing. So, and we have some pretty good pools in town to do that. There's some water aerobics. I always encourage that. Um, I think anything where you're swimming also has excellent mental health benefits, but it's really, really good, on your spine and also working your core. Other things are good too. Running's a little harder on your spine. Um, stair stepper I think is okay. Anything that's not like heavy impact, like the same thing with elliptical. Biking is good. So like tons of kind of good stuff to kind of keep you active, but also really just kind of making sure you're optimizing your overall health. Healthy lifestyle. I mean, I know we hear this all the time, but I have to say, bone health is such a critical thing that I think is just not I think we all have to have it, so it needs a lot of attention. It's important for everybody, and I feel like it can be overlooked. Just even at the very baseline, making sure you're getting enough calcium which you can overdo calcium. So, talk to your doctor if you have any concerns about that or have had any issues with calcium in the past, but at least making sure you either get it through dietary measures or possibly take a supplement. And so I would talk to your primary before you start taking something, but um, having enough calcium is absolutely imperative to keep your bone health as strong as you can. It's something you can do that will help that. And while there are factors outside of your control, this one is in it. Vitamin D3 is also absolutely critical for a lot of systems, but a lot of, especially your bones, it's super, super important. And it's currently the number one deficiency in America. So I take vitamin D supplementation. I have my daughter who's 7 taking a vitamin D supplementation. I do not see a lot of sunlight. So, but even if you do, most of the time, when I would be testing people before fusions, where it probably matters the most, I'd say probably about 80% of my patients were insufficient or deficient. And the ones that weren't were on the low end of normal. So that is a super critical and easy thing to do. It's well tolerated. It's hard to overdo. It's a really important um, thing and something easy that you can do to help really, I mean, it also helps a lot of other systems in your body, but it's an important one. Okay. Avoiding smoking. This is probably one of the things as a neurosurgeon, I've seen a lot of complex stuff and I've seen people in pretty rough shape from brain tumors to aneurysms to head bleeds to run-of-the-mill disc herniations. But I think that in my lifetime, what I would probably be the most helpful for, like the most help I will give somebody is yes, treating their neurosurgical problem, but actually if when I can get people to stop smoking, I am probably doing them more good than anything else I can say about the spine. So I truly do think that avoiding nicotine is probably one of the absolute best things you can do for your body. I'd say if there is one thing you should never do, it's smoke. And if there's one thing you should absolutely do, and I just had to pick one thing on each side, I would say it would be like a low aerobic exercise. Um, it just makes an absolute huge difference. Limit excessive alcohol. I mean, I think we all know the impacts on that. That isn't quite so much a direct bone thing, but an overall health and nutrition and recovery. Healthy, well balanced diet and maintaining a healthy weight. We all hear that too. The biggest thing with the weight, it's just the straight mechanics. It's just like most of our spines are about the same size. And so if I don't know if you guys see, I'm not that big of a person. I'm just kind of petite. And so, but like if my spine has to lift me, but like my spine also is the same size as your spine and you're happen to be two times bigger than me, which, is not necessarily unreasonable for a man. Your spine's going to have to do more work over your lifetime. I mean, every day it's just lifting more. So it does impact how those cushions and how much they have to hold. And that actually goes into even just heavy lifting of boxes and weights and things like that. When you lift it, your spine has no idea to know, like, oh, this is just a temporary measure. I shouldn't wear down from this. It's just got to do the mechanics. It can't think like that. So you're putting that extra stress on your body, which is why it's better to do, as much bending and lifting properly as you can, but also optimizing your core and kind of trying to maintain as healthy a weight as you possibly can. Once again, though, that being said, optimizing your core takes about a third of the load off the spine. And so that is, I mean, if you look at it that way, that is going to be more helpful. I mean, 5 pounds of weight loss, 5 to 10 pounds of weight loss, great. But if you can optimize your core, it's going to take more than 5 to 10 pounds of stress off your spine.
Okay.
Okay, what to avoid? So this goes back into posture. I mean, I think tech neck's kind of a really big thing we see. I mean, it's even in kids. Um, that hunched over looking down at the phones or iPads, things like that. And so this is actually a diagram that shows,
Yep.
normal alignment where your spine is centered. And then as you bend forward, how much heavier your head gets on your neck and how much stress it's applying, particularly to the joints posteriorly and the muscles that are helping hold your head up. So it's just like, if you try to hold something at like the farther out you get, if you get to a 60-degree angle like this, I mean, your head, which is about 10 to 12 pounds here, becomes 60 pounds. That's that lever arm effect. And that really will wear down your neck very quickly. So, I'm a surgeon, so full disclosure, I mean, I'm bent looking over a fair amount of the time, but to combat that, I'm constantly doing exercises to open up my shoulders, roll my neck, and try to really stretch and kind of optimize my posture for all the times that I don't need to be like that to actually do my job. Yeah, so I mean, I think this is pretty impressive. If you go to like a full 90-degree angle, the amount of stress on your cervical spine, the excessive force, I mean, they couldn't even, it really wasn't easily measurable. I mean, it looks based if you just look kind of at these numbers and put it over 90 pounds, but they really didn't have a good way to quantify it. Okay, so now I was just going to talk about some common conditions that we see and that people can have, probably the most common being low back pain. So about 84% of all adults are going to have low back pain at some point in their lives. Um, it is incredibly common. I think if you live long enough, you will have low back pain. So we kind of deem it as acute, subacute versus chronic. So acute is less than 4 weeks, subacute between 4 to 12 weeks, and then chronic anything over about 3 months. So low back pain, it is a very common problem. Luckily, it does not commonly need surgery. Doesn't even commonly need imaging. Most of the time, it gets better. Numbness and tingling is considered a sensation like pain, but it is not by itself indicative of an emergency. I do understand that it is a little alarming when you can't feel your hand very well or your feet very well. And there are certain things that we'll go over here that would prompt you to get a more urgent referral. So these are what we call red flag symptoms. So if you are having fevers, chills, any weakness, particularly sudden onset weakness in like a limb or your foot or your hand, or if you can't lift something, you're dropping it and you could do it yesterday, those are all really good reasons to come in and get looked at, probably in the ER, especially like if your foot is dropping or you lift over your head and you can't like keep your tricep straight, we call it tricep drop. Those are all pretty critical. Not being able to use the restroom or control your bowel or bladder, especially acutely, is super critical. Foot drop, like I said. The fever and chills is actually hinting at infection. We want to make sure there's not an infection of the spine or an abscess. These are very rare, but they are an emergency when they happen. Okay, so what should you do? So, not factoring in these red flag symptoms, really you just need to give it time. Which myself included, if I'm in pain, I don't want to hear that. I get it. It's like I want it better. So I feel you on this. But I think it is reassuring to know that most of the time it is something benign that isn't going to need anything done and it will improve. And so a lot of times we just spend time. Part of my job is just to reassure people that we can watch this and, if it gets worse, we can do something. But if not, we can get it better or you'll get better. Some of the conservative things you can do is some Tylenol over the counter. Don't take more than 3 grams a day. If you have any liver issues, obviously discuss that with your primary. If you have any concerns, discuss it with your doctor. Anybody on blood thinning medication, which are anticoagulation, is cited with liver disease, blood thinning medications should talk before taking any history of ulcer or really bad like reflux, anything like that. Definitely don't start taking NSAIDs, certainly not regularly, or aspirin without talking to your primary. There are many over-the-counter pain patches, creams, ointments. There's lidocaine patches, which recently came over the counter. They used to be prescription a few years ago. Salonpas, Biofreeze, Icy Hot, Voltaren gel is now over the counter. That is a topical anti-inflammatory that I have personally, the warnings on the box look pretty scary. I talked to a pharmacist about it and they have assured me that it is really, I mean, if you're using it as prescribed, that it will not be absorbed systemically enough to cause a lot of problems, like if you're on blood thinner. Certainly feel free to talk to your primary about it, but I went to some very well-trusted pharmacists to make sure that I wasn't advising somebody to do something that could interfere with any other anti-inflammatories or any other blood thinning medications. Alternating ice and heat. I will say if you just an ice an area, it'll be nice and numb, but then if you go to move or something, it might be more likely to strain because that muscle is going to be locked up. And so sometimes doing some ice followed by heat or some gentle stretches or maybe even just rubbing the area a little bit to kind of warm it up is better. Um, Resting, I think if you have, pretty severe back pain, you're lifting something heavy, your back kind of, we'll say, throws out or goes out, like we commonly hear, giving it a couple days of rest, walking around's okay, but, I would avoid the whatever made it hurt in the first place if you can. But really, we don't want you doing anything or being on bed rest for, more than like a day or two, max 3 days. Um, kind of slowly return to exercise, start with some gentle stretches, make sure, because a lot of times what some of this pain is actually muscle spasms. Or you have a joint that's inflamed or a disc that's inflared or has bulged, and then it's your muscles kind of reacting to try to protect your spine, but it does cause a lot of pain. Okay. Sorry, it didn't do this before when I gave it a run through. Okay. What can you do to prevent back pain? Staying active, like we talked about, maintaining a healthy weight, staying hydrated makes you less likely to have some muscle cramping or spasms. Um, don't smoke, using good body mechanics, practicing safe lifting techniques and bending techniques. So, bending with your knees, with your chest up, and keeping whatever weight close to your body. And then core and back strengthening exercises like gentle yoga. Or isometric exercises, anything where you're kind of activating your core, but not necessarily doing heavy lifting.
Okay.
Okay, so I was going to run through a example patient here. One sec. We're going to meet Scott. Scott is a 60-year-old gentleman, construction worker, who has occasional history of low back pain, typically improves with a few ibuprofen. Coming in today to see his primary, he has some low back pain and right leg pain. He notes that this has been going on for about a week of the low back pain and then about 2 days of pain going down his right leg. Anything that makes it worse is just anytime he's upright, anytime he's bending, lifting, walking, standing, really the only thing that makes it feel better is laying down flat. He goes to see a chiropractor. He ends up going to the ER. He ends up getting some pain meds and a muscle relaxer. His x-rays show what we call degenerative changes, which is another gift that if we all live long enough, we will have some. Once you're probably about 30 or 40, you're going to have a little bit of degenerative changes in your spine, and then it just keeps going from there. So his first visit, on his exam, there was none of the red flags, no acute weakness, no strength deficits. He doesn't have any fevers, chills. He's been able to control his bowel and bladder function. And so we call it acute low back pain with right-sided sciatica pain. Technically, the sciatic nerve is a specific nerve that goes down the back of your leg, but it's commonly anytime you have leg pain, no matter where that pattern is, it's generally before we have a really good idea of where, like what imaging is showing or anything, they'll call it sciatic pain. Differential diagnosis could be lumbar strain or a groin strain or herniated disc. So conservative plan, continue the pain meds, the muscle relaxer, sometimes like an oral steroid. Obviously that needs to be coming from a physician, with mindfulness to other underlying comorbidities. Doing some home exercises, stretching program, kind of taking it easy, doing some light, like not doing heavy lifting at work, and then follow up in a week. So things that physicians can do to help in these scenarios include muscle relaxants, which a good portion of the pain is actually muscular in nature. The non-steroidal anti-inflammatories or NSAIDs, which is like ibuprofen and naproxen. Oral steroids, sometimes we'll call it a Medrol dose pack or prednisone taper. Those are some things we would say. And in very rare cases, I think a short-term narcotic pain medication. I will say right now, narcotics do not help nerve pain. They just don't do the trick. They kind of blunt everything to some degree, but true nerve pain usually is not helped at all by a narcotic. Referral to physical therapy. So we want to work on that core strengthening. Also back strengthening. I like them to do myofascial release, which is where they're loosening up the covering of the muscles. The covering of the muscles and every muscle in your body is called the fascia. And if the fascia gets really locked up and tense, it's hard for that muscle underneath it to loosen. So I have them do some, it's basically like a deep tissue massage just without any like lotion or oil, but they kind of work where that muscle inserts, and it can be a little painful sometimes, but you really need to have that muscle loosened to be able to kind of get your spine back in better alignment. Um, Pain management, therapeutic stretching. They can sometimes do some decompression maneuvers, kind of help open up some parts of the spine. Also, then refer to pain management. Pain management can do different type of injections. An epidural steroid injection is putting a focal amount of a steroid, a liquid steroid, into the area of pain to help decrease the inflammation. It does not make the problem go away. It actually kind of calms the inflammation down while your body is handling the problem.
Okay.
Trigger point injections also help. Those sometimes your primaries can even do. Um, with ongoing symptoms, some of the imaging things we would talk about is possibly getting some x-rays. That's usually where we start. Um, MRI, usually it's not super helpful if somebody comes to see me without an MRI because I really need that to like look at the nerves in detail. A CT myelogram is a phrase that you might hear. If you have a pacemaker that is not MRI compatible, sometimes we'll ask for a CT myelogram, which will inject dye into the nerve sac and be able to highlight the nerves throughout the entire spine. And then we do the CT to see the bones, and then the contrast shows us where the nerve areas are. So it's not quite as detailed as the MRI as far as the nerves go, but it's the best option for people who can't have an MRI. And then an EMG or nerve conduction study is something that we do when we're trying to kind of tease out which nerve, or whether it's coming from the spine or maybe coming from like carpal tunnel or peripheral nerve, something along those lines. So,
Kelly, excuse me, I'm sorry. There's a question here. How is a trigger point injection different from a steroid shot?
so a trigger, so in an epidural steroid injection, they're actually injecting the medication into your spine, like not into the nerve sac, but they're actually putting it so the epidural means on top of the dura. The dura is a leather-like covering that is holding all of your nerves in your spinal cord. So
Okay.
they're putting that on top of the nerve sac. So you want somebody who's pretty used to doing this because you're sticking a needle awfully close to your spine. So these are people who do this every day. They're well trained. A trigger point is more targeting. They're going to do those in. I think there's a variety of different things they can do, but into different muscles that might be knotted. That's my general understanding, is kind of doing a little, like there's smaller amounts. They could do a few of them, and it's more targeting different areas that could be knotted up, kind of more in a muscle area, and maybe even over a joint. But those can be done because they're not as specified. Those nobody's putting like a trigger point isn't going to be right by a nerve or the spinal canal. So they're more focused kind of like more laterally along a muscle that could be really knotted up, and it'll help loosen that.
Okay. And this is mildly off the subject where we are right now, but this rings with me. Someone asked, what's the safest approach to pulling weeds? Uh, this involves leaning over. First thing I
Um,
want to say is hire a gardener, but if that's not possible.
okay. Yes, agreed. I do say that. This one's funny. There's a few things I never thought I would grow up and talk about so much as I do, like lawn mowing, weed eating, gardening, and golf. Things that come up on my radar. Sorry, I'm gonna get this light out of my eyes. Um, okay, so I'm gonna do my best to show you. I would advise people, if you just are passionate about weed eating or you really just don't have another choice, I would try to get one of those foam pads that like, this is gonna sound weird. There's probably better options. I'm not a gardener, so that's gonna come out here. But like that you would put by a bathtub, like for with kids, and then basically, this is also gonna be a little awkward, but I'm gonna do it. Like kind of sit like on my knees, and so I'm like on my knees on a pad and keeping my chest up as much as possible, and like kind of being low to the ground, but just trying to minimize how much you're bending over. If your knees can't take that, which I have many patients who that's the case, I, make your children do it, make your husband do it. I mean, obviously, like I said, I don't do this, but Um, maybe throw some weed, like stuff that dissolves the weeds. I don't know. Is that a thing?
Uh-huh.
This is not my lane, but I do generally try to tell people to do it with the best posture possible. It is annoying. I would say take frequent breaks. You're going to have to like move. You want to be as close to it as you can so you're not bending over. So,
Right.
wearing gloves, trying to sit right up on it and pulling it straight up while still activating your core isn't really going to stress your spine. I also do understand the practicality of that is not super high. So, anytime you're doing something that's going to bother your back, you can usually tolerate it for a little while. And so you just need to do it in shorter increments and take more frequent breaks.
Someone mentions you can sit on the foam pad and weed. That person says they do that.
Yeah. Yeah. I
Yeah.
mean, I think it's doable. I mean, I've had people come back and say that's an option.
Okay.
Um, yeah, or knee pads, things like that. I mean, the weeding is hard, but I know some people have planters that they've now like elevated instead of having to do it, they have like plants in the garden or whatever that are like a little bit higher up that makes it easier for them.
Yeah.
Um,
And there's also a question going back to the trigger points.
mhm.
Someone says they went to LMH therapy. They did dry needling for trigger points. It solved the issue. Do you
Yeah.
recommend needling, which actually is acupuncture, isn't it? It's called dry
Yeah, it's very
needling.
similar. I think the techniques are slightly different. But so there is not super great evidence in spine literature to say that, I mean, I think these things help when they're targeting, if you have a true like nerve compression, is that going to take care of it? Probably not. But most of the time it's muscle pain. So loosening up, my understanding is that the dry needling is going into the fascia and disrupting that. Similar to
Right.
what I was talking about by doing that myofascial release, it can loosen up that knotted fascia and open up and kind of disrupt that fascial, I'm going to call it clumping. That's probably not the right exact description, but and so I agree with that. I also am very open to things that like as long as they're not going to do you harm, I'm okay with trying it. Like I think acupuncture is safe. Dry needling is safe. Um, I think in certain circumstances they both can help. I'm not a Western or like an Eastern medicine expert as far as the acupuncture goes, but I've done it myself. So I have my husband also does it. He loves it. So I think that all of those things are very reasonable. And I think a lot of those people, the physical therapists, the pain management doctors, they're also very good at assessing this. Like, I mean, I don't do trigger point injections, so I know kind of what the goal is, but that's not even something I do. So, but the people who are doing those things, I think trying a lot of those remedies can be very effective. I've had people have very good luck with dry needling and acupuncture, and trigger points.
Okay. Sounds good.
Okay. So Scott comes back at his 1 week follow-up. His back pain has improved, but his right leg pain's a little bit worse. He has been taking the pain medication as well as the muscle relaxer and completed the steroid dose pack. He is able to get around, but he is now using a walker when he is upright. He does not have any of the red flag symptoms we talked about. So we talk about continuing an anti-inflammatory. Sometimes we're hesitant to give steroids and anti-inflammatories at the same time. I can be because they can cause issues with reflux and disrupt your kind of irritate your esophagus. If you have any of those issues already, you need to be mindful of that and make sure you're taking them with food. And in those cases, I wouldn't take a steroid dose pack and an anti-inflammatory at the same time because they would just make any underlying reflux or GI issues probably a little bit worse. So being mindful about that, getting ready to start physical therapy and then have him follow up in 2 weeks. Okay, next follow up. So it's been about 4 weeks since he had the acute onset of back pain. He's doing much better. He is not having any leg or back pain. He completed physical therapy, is off the pain meds, does still have some numbness in the right leg. He is ambulating without difficulty, doesn't need the walker, is able to bend forward and extend mildly in normal limits. His strength is we rank all muscle group strength out of a five. Five's like max strength. So 5 out of 5 means they're fully intact muscle wise. No distress. So at this point, plan to return to work without restrictions. The short physical therapy, no imaging was required, no surgery. I would say this is the patient that doesn't see me. They don't need to see me. I would be a waste of their time, and they'd be well better probably before they got in to see me. So primaries do an excellent job of this. They handle this all of the time. So going on to some things that, let's say Scott didn't get better. And so at some point, some more imaging is needed. So this, I'm just going to kind of go into some common lumbar pathology and kind of what the pathology of that is, the prognosis, and kind of what we do to work through that. So we'll kind of talk about surgery options versus conservative options and when you might need either one. Okay, so this is a pretty good summary of like how the pathology of the spine, particularly in regards to the discs, wear down. So we start with this nice cushion. This is the disc. This is a side view of the spine. So like the person would be like staring at the wall and I'd be looking directly at them. And so a normal disc is nice and healthy, has this nice pad. Then as it starts to wear, you got to get these cracks. And so it starts to collapse a little bit. There's certain ways that this can appear. We call this degenerative disc. This is what I said, like if you are lucky to live long enough, probably until I'll give it 40s, but realistically, probably less than that. You're probably going to have one of these at least somewhere in your spine. So that just means it's getting a little dehydrated. It's not as moisturized. It's all of us, it's winter. We all of it could kind of shrink down, not as hydrated. It's not quite the same pathology for the disc, but it's a wear and tear kind of stressor where it's just like a little bit of the fibers within the disc have kind of torn. So a bulging disc is where there has been pressure on it, and there is the middle portion of the disc is different than the outer portion. The outer portion is like a tougher ring, but it also could dehydrate faster. And then the inner portion is a little bit more like volume and hydration to it, but it can easily, because of that, have like press through that outer ring, and so or just cause the outer ring to bulge. It may not have like fully herniated outside of the disc, but it will cause pressure and bulge back. It's like if you had a hamburger patty and it was really thick and you just kind of keep pressing it down and down, it starts to bulge all around. That basically can happen. The only part it really is a problem is when it bulges towards the nerves, which is this area here is the what we call the nerve foramen, or I call it the nerve tunnel. It's where the nerve exits out of the spine, and one nerve exits out of the spine at every single level in your spine. So this is a model. This is a side view. I don't know if you guys can see this very well, but like these yellow things are the nerves.
Mhm.
So this is the front, these clear parts of disc. This is the back. This would be the part you can touch. And then straight down the middle is like the spinal
Spinal cord.
nerve sac. Yeah, the spinal cord. The spinal cord ends around the bottom of your thoracic spine or the very top of your lumbar. And then it becomes like a free floating sac of your lumbar nerve roots. So with that, once this is bulged, we know that it's worn down. We've kind of worn through that outer layer. There's a part that's a little weaker now. And then with enough wear or enough time, part of the actual disc itself will herniate. It will come out of the disc space and actually move into the space that is for the nerves. We see this pretty commonly. Luckily, this also gets better. About 75% of the time, it has resolved and is improved by about 6 to 8 weeks. So it can cause leg pain, it can cause back pain. It's a bigger issue if it causes weakness, particularly like acute onset weakness. And so this is a very common problem, but luckily, even with this, it does tend to get better. So this is like a thinning disc. So this we'd say is degenerative, but it's like a severely degenerative. It's really collapsed down. It's taken a lot of pounding. It's worn out. There's not much hydration there. There's not a lot of good healthy tissue there. And with time, as that happens, there's more stress. And so once it's very thin, and we call, sometimes people will say this is bone on bone. We don't usually describe it that way, but once this is severely degenerative disc, it will start to affect the bottom part of the bone and the top part of the bone below it, the end plates, because they're the ends of the two vertebral bodies, and then you'll start to get some bone spurring. The bone spurring occurs because it's basically trying to almost be protective. I obviously clearly it's not thinking through this way, but I think of these degenerative changes. I'm like they're basically trying to like they kind of overgrow as a way to eliminate stress. It's almost not quite trying to autofuse, but that's like the intention is like you'll see these bone spurs that kind of hook to the next level. And it's trying to stabilize that disc level because it doesn't have as much strength as it did before. And while this is happening in these discs, there's also a lot of stresses that tend to also be going on behind in the ligaments and the joints that are on the back part of the spine. Okay, so this talks about ruptured disc, sciatica, which is we actually commonly call it a radiculopathy, and we'll usually use the nerve root that is the most affected, versus a bulging disc, a herniated disc, and like, yeah, so here's a radiculopathy. So normal disc, this is the center, here's the outer ring. This is the nerve sac. We're kind of looking straight down, like if somebody was like laying on their back, but we kind of cut them off midway and we're looking straight in. So here's the back part. That's the spinous process. That's the part of your back you can touch, kind of the bony part you can touch. The nerves are underneath this. They're protected by the bone, comes out, and there's some joints here. And then the discs are in front of it. And so when this middle portion, which is the squishier part, breaks through this part after it's worn down, that's what starts causing pressure on the nerve sac and or the nerve root. And this
There's a
can
quick,
happen anywhere in the spine.
there's a question here.
Sure.
Is thinning considered stenosis? And we've all heard of someone having stenosis or surgery for that.
Mm-hmm. It's very common. Thinning, it can be a contributing factor to having stenosis, but just having disc collapse or disc thinning doesn't mean you have stenosis for sure. The idea is that, see, I'm a very visual person, so I use a lot of tools when I see people. But so like if your nerves are coming out here, like this nerve tunnel, I'll say this one,
Uh-huh.
and then we push this down. Oh, this okay. This is not my best level. I'm gonna have to use the broken part just for emphasis, but pretend the bone's not broken. So when that collapses, you can see where that nerve had height
Hmm.
here.
Yeah.
And then now, like that would be if it had normal height and normal bone. And then when that's all really worn and there's no space between the discs, it does cause, it basically lessens the height of the nerve tunnel. So it can be a contributing factor to stenosis. Stenosis comes from the word stenotic, which just means to narrow. So it's anything that causes narrowing around the nerve sac or the nerve as it's exiting out. And a lot of times it's a combination of there's less, the ceiling height on the nerve tunnel has collapsed. So that does leave you with less space to have to begin with. And then when your joints start being, which is this back part, when the joints, you have one on each side, start overgrowing, we call that hypertrophy. So if you read your MRI and it says there's facet hypertrophy, that is just saying that the joint is arthritic and it's been stressed and it's overgrowing. So I kind of explain it like it's all getting weaker. The whole spine's getting weaker. And its thought is like, oh, if I overgrow, I'm going to be like helpful. I'm going to get stronger. But it's like, no, you're not helpful. You're just making a small space smaller.
Smaller.
Because it's just like if you have arthritis in your hands and your knuckles. So, I mean, it's annoying if you try to put a ring over it and it can hurt sometimes. But if you have that and you have one of those joints on each side, right behind the nerve sac, and they grow, they're going to grow out as much as they grow in. And so they cause pressure on those nerves as they're passing by.
Okay.
Like
There's
this could be, yeah.
another quick question. Can you explain spondylosis? Spondylosis?
Yeah, spondylosis is kind of a fancy word for basically describing what we just said. Um,
Okay.
lumbar spondylosis is basically saying that there is disc degeneration. It's um, that is causing like the spine is worn and that it's in this process of aging and is having some collapse of the disc.
Mhm.
Um, yeah.
All right. And then one last quick question. How does a herniated disc heal? On your picture here, the red area of the
Yeah.
diagram, is that fluid? Does it absorb?
So it's
Rest?
usually not fluid. It's thicker. Hopefully this doesn't gross anyone out, but it's probably the consistency of like crab meat is the
Okay.
closest thing I can think of.
Okay.
Sometimes it's a little juicier, sometimes it's pretty worn and dry, but it's the longer it's outside of the nerve sac, sorry, um, the more dried out it'll get, and it'll eventually shrink down. So that's the thing. It will bother the nerve. It basically just walked into the nerves through the nerves back door here. It's not, the nerve is not happy. But over time, as it becomes more dehydrated, because it's not where it's going to get healthy nutrients within the disc, it will dry out and kind of shrink some on its own. And then your body actually has kind of an inflammatory pathway that will go after it. There
Okay.
are these cells called macrophages
Mhm.
that are like essentially trash cells, and they'll go pick up stuff where it's not supposed to be, and it'll help break that down. And that can take about 6 to 8 weeks, and that's why it usually takes about 6 to 8 weeks for it to be better. That doesn't necessarily mean that, which you don't need, like you got an MRI 6 to 8 weeks after you have a disc, that it'll be gone. A lot of times it just shrinks down, it kind of becomes a little bit hard, but it's not causing that inflammation. A lot of the issue is like you can have a disc but still have space for the nerve, but the nerve can be very unhappy. So it's a pressure phenomenon, but it also causes a lot of inflammation that makes the nerve unhappy. So if somebody went and injected a epidural right here, right behind, right into this space, below, like right between two bones and like on top of the nerve sac, and that steroid spreads out here, it's just calming the inflammation down. It doesn't actually do anything to the disc itself. It's just making the inflammation chill out basically while the body's taking care of it.
Yeah. Okay. Thank you.
Was that helpful?
I think so.
Okay. Um, so here is another example, kind of somewhat similar pathology, but you can see how it's really, just looking at an MRI is not enough for me to say something needs definitively done because I've seen people who have terrible MRIs, but they're doing great. And I can't make you better if you're doing great. Um, I'm here to treat the patient, not the MRI. And so, um, but we also do discuss things to help their spine not get worse. So here, Charlie, we got a 63-year-old gentleman, has a history of 1 year worth of back pain and bilateral leg pain. It has gotten progressively worse over the past 4 months. He's tried anti-inflammatories, muscle relaxers, stretchers. Um, he has pain with certain movements, but no red flag symptoms on exam. So plan is to try a lumbar epidural at the level of the disc herniation. So this Andy is a 63-year-old with 6 week history of low back pain and left leg pain and left foot weakness with numbness and tingling. So I feel like sometimes people think, we very much care about leg pain. I mean, it actually is very important for us to know that. But having weakness becomes kind of like brings the acuity and this like stress of it or the importance of it like a little up higher on the totem pole. That's the person we're thinking may not fall into the category of just getting better on their own.
Yeah.
Um, on exam, he has a left foot drop and left leg weakness. This being said, I am going to say this left foot drop has been there by the time he's seeing me, it has been there for 6 weeks. It's not brand new. It did not happen today. It did not happen last night. If somebody comes to me within 24 hours of having a brand new foot drop, usually through the ER, that is actually when we would look at doing something more urgently. If your foot is dragging and it wasn't yesterday, you should go to the ER. Um, that is very rare, but it is what we deem like a neurosurgical emergency, or it can be a sign of that. It's probably the most well-known sign. So this is a red flag. So it's still going on. There's still a chance it could get better on its own. So, and sometimes this is the point where you say, okay, you're right at the 6 week mark. You're right at the level where it should be getting better. Do you feel like it's getting better? Do you feel like it's getting worse? A lot of times people are like, I don't know, it's miserable. I don't know. Please just make it stop. And so then, we talk about it. I'm like, well, we could give it another week or two, see if it gets better on its own because you're right at that threshold. Or we could try more conservative things, which would be taking the anti-inflammatories, especially if none of this has happened yet. Doing some physical therapy. They could do some lumbar decompression therapy, um, kind of like avoiding heavy lifting, straining, things like that. So what this kind of talks about some symptoms that can cause disc problems or what you get from that. You can get low back pain. I think it's more of the inflammatory response that's happening there. Like, and if you get an epidural and it helps back pain, that is more of like an inflammatory thing that it's helping. I say that because sometimes we're looking for back pain that has like a true mechanical instability, which we're not there yet, but So sometimes when we're asking you to like differentiate like, how much back pain versus leg pain, which is a common question we ask, because it kind of helps us like, is this like a structural integrity problem? Like, is the spine unstable? Is it moving? Is there abnormal alignment? And so some of those questions can help with that. It can also cause pain, numbness, or tingling in the leg, or all three. Weakness of the leg or foot. Basically, people are kind of shifting. A lot of times when I see somebody with a disc herniation, they're kind of like leaning like this, like they're kind of like shifting in the chair. They can't really get comfortable. Sometimes they're laying, sometimes they're not. They stand, they're kind of all over the place. Like I could walk in and probably be like, you have a disc herniation just by seeing how they're standing.
Mhm.
Um, and then it usually like I tell people, I'm like, with one finger, kind of show me the pattern of the pain in your leg, and that'll usually localize this to one nerve root, possibly two, but usually one nerve root that then would give me an idea without looking at the MRI, although I usually have by the time I clearly do have if we have it, um, of what area I think is the problem, just by the nerve pattern that they're telling me. And so that's based on this. It's called the dermatomes. So this is like when somebody asks you if you go see anyone, they're like, where is the pain? Ideally, what we want you to do is say, starts on my back, goes down my lateral leg, over my anterior knee into my inner shin, and stops at my ankle, like L4. Like it's like reading a book to us. But that is not how pain commonly works, and I know that. When I have pain, I'm like, well, this hurts. Like I don't have this perfect pattern, and it doesn't commonly present in that. But a lot of times when people are asking you to kind of localize or describe it, they're trying to pinpoint to what nerve could be affected. Or if sometimes it can cause pain, let's say if you have numbness and tingling from here all the way down through your foot, from your kind of, we call it like stocking distribution, like a sock, like that could be more of a peripheral neuropathy. So there's different patterns that give us a hint as to what's going on. So the MRI findings, we're going to say that both Charlie and Andy showed up with an MRI that showed this. So they had several similar symptoms, including back pain and leg pain, but then they each had separate symptoms. So here, this is a side view on the MRI. So these are the bones. This is the vertebral body. This is the disc space, a normal disc. And so you can see that it's gray. It's a lighter gray than this. When the discs become degenerative and start to wear down, you can see that there's more height here compared to here at the bottom. And that this one is black. So sometimes they'll say, oh, you have a lot of black discs, and that can mean that that is a degenerative disc. It's lost some of that hydration. That's a marker for us to know that it's on that pathway, along with the fact that it's also lost height and part of the disc has come out. So this is the part of the disc that's herniated. It's pushing into the nerve sac. This is the nerve sac. The brightness is from the spinal fluid that surrounds all your nerves. This is the bone in the back that you can feel on your back usually. And so it's pressing one of the nerves, likely S1, the S1 nerve, which goes basically straight down the back of your leg into the bottom of your foot.
Okay.
So follow-up. Charlie, 1 month follow-up. He says both his back and leg pain are 75% improved by the epidural. He's able to be more active. He can walk further, less pain. He is okay. So much for going too fast. It looks like I'm at my time. Do you want me to keep going?
Um, I
We
think,
we have some questions, perhaps.
Okay.
uh, yeah, there's two questions in the chat box. One asks, does degenerative scoliosis mean the condition continues to get worse throughout one's life?
It does commonly. Yeah. Not usually rapidly, but yes, once you start to have what we call progressive scoliosis or degenerative scoliosis, it's the development of scoliosis is like if one joint is overgrown or loosens, like so sometimes we would see like if I'm facing you, this should be straight, but maybe one will kind of start to bend this way. And so it's like your disc on one side would wear down and it'll collapse that way, and then it'll start to shift over and your joints become incompetent. It's really like a 3D, like a full rotational component. But you can have rotation of the spine, like it can twist, it can bend, it can shift. This is like spondylolisthesis is when the bones move on one another. That's a common thing.
Okay.
It's like stair stepping off, and that can cause a lot of actual what we call like mechanical back pain. Like that's when we're saying like, how bad is this back pain? And like we ask certain factors to determine if it's that kind of like instability type of pain.
Okay.
which needs a different treatment than just taking out a disc. And so it is likely to progress, but the best thing you could do would be to optimize your posture, your core, do like some gentle yoga. There's like even ones you could probably find online, like gentle spine yoga. I mean, even planking, if you can plank, you can do it on a bed, you can do it on your elbows, you can do it on your wrists.
Okay.
Just planking and holding your core really tight for as long as you can is really, really good for your spine. It's just doing anything to activate those muscles. Honestly, just holding yourself up in really good posture is using your
Yeah.
muscles. And so just kind of having a reminder to kind of keep you on your toes that way, and doing things like I like deep tissue massages because they help loosen up the muscles, because sometimes the muscles are locked up and that can actually kind of pull you one way or the other, which can cause more stress on those joints over time. So if you're able to get like regular deep tissue massages, I always would advise that.
Okay.
May,
There's a,
may I add something here?
Yeah,
Is that okay? It's not written on the
sure.
box, but I'm Mary. I'm 86. I've had a pretty severe scoliosis from adolescence. I'm at 86. I'm doing okay. I don't get a lot of pain from it. Just FYI, it's T11 through
Yeah,
L3. And so it involves five vertebra and it's 52 degrees. So it's pretty severe in that
pretty
area.
severe. Yeah,
And the important thing I've been told again and again is core muscles, keep
yeah,
them tight. I
yep,
like your idea of the plank. I think that's a good
yeah,
idea too.
yeah,
And I've had PT to
yeah,
where I sit on a big ball and then I'm really focusing on those core
yeah.
muscles and removing the leg
It kind of
involvement.
makes you stabilize your core. You kind of have
Yeah,
to.
yeah.
You don't really have a
And
choice.
I'm doing pretty well with it.
Yeah,
I
yeah,
use
it's
a
wonderful.
cane. But yeah.
Yeah,
And may I ask a question about kyphosis?
of course.
You've been talking about lower back pain, but I do have a kyphosis. It's gotten
Hmm.
worse with years.
Yep, which is
Lots of
common.
book reading during my career,
Yeah,
and
yes.
I've not enough exercising. I've done lots of exercising for it, and I try to keep as straight as I can rather than lean
Yep,
over. But I can't remember. I have to think to straighten up, and so
yeah.
I look like a very old, doddering lady sometimes. And is there a method you can suggest to help people remember to stand up straight rather than just automatically relaxing into this position that we might have been using for a long, long time?
Yeah. I mean, so some people have different things. I mean, for kyphosis, I'll tell you, just actually like strengthening so much of that, I think because you tend to be more kyphotic in your upper thoracic. And
Yes.
as we bend over and we're used to reading, even our muscles here will contract. And you can actually have a therapist go and work on it's called your brachial plexus. They can do
Oh,
that
okay.
myofascial release. And I probably roll my shoulders, I kid you not, probably 100 times a day.
Okay.
After I operate and I'm all hunched over, I like come out and I just like open all of this up. And it's not like a natural feeling. I've really had to train myself. But like rolling your shoulders, shrugging your shoulders, pulling your shoulder blades back together, and kind of really like I said, like trying to be as tall and open as you can. It feels funny. You don't have to do it in front of other people. But I think that really is helpful. And as I said, I'll kind of view it as like a reset. So like I roll my shoulders, but it actively like gets my neck up, my shoulders down, because a lot of times we're always guarded like this too. So it's pulling them down and then
Hmm.
activating my core. You can't see me, but like I might, when I say activating your core, it's like that idea. If you thought somebody was going to hit you in the stomach, that's what activating your core is. You kind of guard them.
Hmm.
And
Hmm.
not that you have to like hold your breath or like grunt or anything, but you want to really be like just basically being as tall as you can. It's the idea of like
Yeah.
if you're going to get your height measured, how would you stand? And that
Yeah.
would be it.
And
So,
great information. And any other thoughts about just these muscle memories are so bad, and when they're
yeah.
bad muscle memory, so ways to try to create new muscle memory to
I
stand up
mean, I
straighter.
think that there are a few things, like whether you have a timer,
Yeah.
whether you like have a certain thing where like after that, like 30 minutes, you reset. And eventually you're
Yeah.
going to start doing it on your own.
Okay.
There are, whether you have it on an Apple Watch or like a little beep or something, or if you're watching a show, at that point. And
Hmm.
so I personally don't tend to sit back in my chair all the way. I sit on the edge of my chair because it
Ah,
forces me to have better posture. It's very hard to have bad posture when you're not like leaning back in your chair.
Yeah, yeah.
And so
Good.
you can also get like lumbar supports that will help you not slouch, that not do that like bottom rolling under, kind of keeping your back upright. I'm sure you can get them anywhere.
Sure, sure. Okay, thank you. Thank you.
Yeah.
Good, good, good.
We are running over, but there's a kind of a comment here. Uh, this person said their entire life they had bouts of acute back pain several times, got unbearable around age 60, spent 2 years in physical therapy, ibuprofen, x-rays, MRI showed many issues. The two spine doctors said I needed fusion surgery, but I got a stem cell injection and I've been totally pain-free for 3 years.
Wow.
I,
Okay.
Wow.
I think there is promise in stem cells. I will fully disclose I don't do them.
uh-huh.
I don't think that for the most part, what I see in the public, um, I would not advise my loved one to do it. I'll put it that way. I'm not going to say it won't be there, and I'm not going to say that it didn't help because I think the idea of stem cells, I think that is the future. I mean, from
Mhm.
a nerve, I mean, I'm very fascinated by that. That's why I went into neurosurgery. Like, I'm very like the idea of like you can't really regenerate neurons and nerve tissue and things like I'm very into that. But what I am aware of, we're not quite there yet. And I've seen a lot of the ones I see are the ones who have infections. And then I have to go in and drill all that out and wash it out, and their backs become unstable. And they have that's kind of the fever, the chills, all those red flag symptoms we are talking about. I've seen a few who have had stem cells, and like I said, I don't see everyone who gets them. So the ones who do great don't need to see me. So it is a little biased, and I will own that. But I have definitely had my fair share of having to go in and wash that out because it got infected, which anything could, but any injection theoretically. But I will say stem cells has happened more than anything.
Yeah. So, and it's most interesting when you mentioned you look at some MRIs and you can't believe the person can walk
Yeah,
and they have no pain whatsoever.
yeah,
And other people you can't see much going on and
yeah, and they have a lot of pain.
they're in excruciating agony. So, the body is a magnificent machine.
Yeah.
It takes care of itself. It's a mystery, but uh, thank you so much. I mean, we could go on quite a time here, but
Yeah, I mean, I'm probably only halfway through my PowerPoint.
oh gosh. Well, maybe we'll have to have you come back again. Thank
Yeah,
you
of course.
so
Yeah.
much. Yes,
That's,
I've got to thank you
this
so
is
much.
helpful.
Excellent information.
Okay.
The critics are speaking. They're all enjoying the information.
Okay.
Maybe we
Very
could
good.
have you again, Dr.
Yes,
Crabtree
absolutely.
Wilson.
I appreciate it.
Okay, because pain is constant when you're old.
Oh,
Um,
yeah. Yeah.
but I have
My
to
mom
find.
says getting old
Oh,
isn't
okay.
persistent.
Somebody says, please have her back. Fabulous. I learned so much. So
Oh, that's very sweet.
we'll do a part 2 on spines. Okay.
Okay. Happy to. Happy to. I'll note
Thank
where
you
we
so
left
much.
off. All
Okay.
right.
And
Have a
thank
good
you
night, guys.
everybody for being here. And
Of course. My
we'll
pleasure.
catch you next time and
Okay.
maybe
Very good.
we'll revisit. Thanks
Okay.
for
Sounds
being with
good.
us.
Thank
Okay.
you.
Bye,
Okay.
everyone.
Bye.